Dependency takes root through a slow, quiet reorganization of the brain's internal priorities. Marcus held a steady job and managed his life for years, while relying on exactly one beer after a long shift to relax. He stayed within a low-risk baseline, showing no negative behavioral consequences. The transition out of that baseline happened without a single conscious decision to increase his consumption. Because there was no dramatic catalyst or obvious breaking point, the shift was almost entirely imperceptible to him as it occurred. This silent, gradual onset renders early warning signs virtually invisible to the naked eye. Substance use exists on a spectrum of behavior, rather than a binary between being fine or having a problem. On the left, the cool blue zone represents low-risk, casual use that does not disrupt daily life. At the extreme opposite end, the brain has reorganized its physical structure and biological baseline around the substance. Almost no one starts their interaction with the substance at this end of the scale. Instead, individuals drift across the continuum. They move from one zone to the next over a timeline of months or years. Because the movement is a gradient, there is no distinct border or alarm bell to signal when someone has crossed into dependency. Accurately assessing use requires tracking this directional drift over time, rather than waiting for a worst-case scenario to manifest. The first measurable internal shift occurs when the historical amount of a substance stops producing the historical amount of relief. At this stage, Marcus was seeking the original level of relief that used to come easily, rather than chasing a larger high. This diminished return stems from a biological mechanism called neuroadaptation. In response to repeated, habitual exposure, the brain's receptors naturally dull their sensitivity to maintain internal balance. Producing the same biological response now requires twice the input. Marcus found that one beer felt thinner and slower to take the edge off a shift, so he added a second one just to reach his standard evening baseline. These early increases in consumption are an autonomic mechanical adaptation, separate from a person's conscious desires. As neuroadaptation continues, dependency splits into two distinct parallel tracks. Physical dependency is the body's pure chemical adaptation to the substance's constant presence. At this point, removing the substance disrupts baseline organ function, causing measurable physical withdrawal like tremors, nausea, or an elevated heart rate. Psychological dependency involves the mental reliance and behavioral planning an individual builds around acquiring and using the substance. These two tracks are independent and often progress at different speeds. For Marcus, the psychological planning, like timing errands to ensure he had enough beer, arrived well before the physical cues of irritability and poor sleep. Behavioral coping structures often lock into place long before physical tremors ever begin. While the lived experience of dependency is subjective, a clinical diagnosis requires objective measurement. Physicians and specialists use the DSM-5, the formal diagnostic manual for substance use disorders. This framework uses 11 specific criteria to assess a patient's condition. The matrix is populated by specific experiences, such as developing biological tolerance, giving up important activities, or spending significant time obtaining the substance. A clinical diagnosis requires meeting at least 2 of these criteria within a 12-month period. The number of criteria met determines if the case is classified as mild, moderate, or severe. There is a specific exception for patients taking medication under active medical supervision. Developing tolerance to a prescribed drug is a normal physiological response. Within a supervised treatment plan, it is not evidence of a disorder. The framework differentiates between the body's adaptation to medical treatment and the pattern of compulsive, unregulated use. This medical exception does not apply to Marcus, whose usage was unregulated and self-administered. The definitive markers of a disorder are loss of control and continued use despite negative consequences. A clinical diagnosis marks the point where a behavior overrides a patient's self-preservation. These diagnostic criteria challenge the assumption that a dependent individual could simply stop if they had enough willpower. Stopping requires more than breaking a habit. It demands undoing an entire architecture of physical adaptation and daily coping mechanisms. The difficulty is rooted in the prefrontal cortex, the brain's executive control center. This region is responsible for impulse control, weighing long-term consequences and overriding short-term urges. Sustained substance use measurably reduces blood flow and metabolism in the prefrontal cortex. The resulting imbalance hyperactivates the neurological hardware responsible for seeking the substance, while the hardware for restraint degrades. While this state is not permanent and can recover with sustained abstinence, it alters the individual's capacity for choice. Just stopping fails because the specific biological system required to execute that decision has been mechanically disabled by the dependency itself. In Marcus's daily life, this compromised executive function was subtle. His external life remained perfectly intact, with no obvious failures at work or home. But internally, the machinery had locked into a new pattern. The shift into dependency occurs in those quiet moments of internal reorganization, when the prefrontal cortex loses its influence and the brain's baseline begins to depend on the substance to function.